now let's start. Now let's welcome Professor Huo to share advanced technologies and concepts in the field of FFR, IFR, and IMR. Welcome, Mr. Huo.
Thank you. Thank you, everyone. I have to say the good morning, good afternoon, or the good evening, because we have different time zone. Thank you, everyone. Let's start. Let me introduce myself. Can you hear me? Okay.
Yes, very good. Very good.
And my name is Yunlong Huo. I'm from Shanghai Jiao Tong University. Today, I will introduce angiography-based hemodynamic parameters for the. Wait a second. For macro and microvascular disease in different patients with ischemia heart disease. First, let me introduce some background for the angiography and also the physiological strategy. In most of the cath lab in the world, the doctors, many doctors, determine if they want to give the PCI strategy or not, just based on the anatomy, and that means from the angiograms, from the coronary angiograms. Based on the stenosis, they will determine, they will put the stenting or not. In some very complex case, they will use IVIS or OCT to determine the anatomical strategy. But in order to determine the myocardial ischemia, the best way is using the physiological strategy. Using the physiological strategy to determine the coronary revascularization is much better than the anatomical strategy. The physiological strategy, there are many kind of physiological parameters. I think the most famous is a fractional flow reserve. That we call the FFR. Most of the people know this part. Another very famous is instantaneous wave-free ratio. That's IFR. Because IFR from the Philips company. But a different company, for example, the Boston Scientific or Abbott, they have different name. For example, they use a diastolic pressure ratio, resting full cycle ratio. Both FFR and IFR used for the coronary revascularization in order to cure the myocardial ischemia due to the coronary stenosis, that's epicardial coronary stenosis. We call it a macro stage. But many patients have the microvascular disease. So Dr. William Feven proposed another parameter. He called it like the index of the microcirculatory resistance. Using the index of the microcirculatory resistance, IMR, we can determine the microvascular disease. That means FFR, IFR are good for the stenosis-induced myocardial ischemia. IMR is good for the microcirculatory resistance. This slide, I'll first introduce some basic theory for the FFR. FFR equals to Q over Qn. Q means the decreased flow rate in patient with the epicardial stenosis as a maximal hyperemia. Qn is a flow rate in the patient when he was in the normal case. But a patient who is normal, he will not go to the hospital to take the test to determine Qn. So Dr. Nico from Netherlands first using some mathematical derivation to derive the FFR equals to PD minus PV over PA minus PV. Here PD is mean pressure distal to the stenosis as a maximal hyperemia. PA is a mean aortic pressure. PV is venous pressure. In general, PV equal to 0. In more than 25 years, there are many clinical trials to prove the FFR, to validate the FFR. For example, the FAME clinical trials has shown the FFR can be improvement of patient outcomes and significant resource saving. FFR is very good to determine the myocardial ischemia. FFR is smaller than 0.8. Normally, we will determine we will decide PCI stenting, but FFR is not good for some patients because if the patient is allergic to the adenosine or some other hyperemia agent, so some other scientists propose a new parameter. They call the IFR, the instantaneous wave-free ratio. Normally, in the diastolic period, there is a small period we call the wave-free period. In this part, there is no wave coming back from the peripheral arteries. In this part, they define they use a pressure ratio like the PD over PA to mimic the FFR situation. But we know the PD over PA is still in the physiological state. We can call it a resting state. It's a little different from the FFR. So the cutoff value is larger than FFR. In 2017, there are two very famous papers published in the New England Journal of Medicine. They found the IFR with a cutoff 0.89 have a very similar result like to the FFR with a cutoff 0.8. The IFR gait revascularization strategy is non-inferior to a FFR gait strategy. IFR is associated with less chest discomfort because the patient don't need a hyperemia agent. In this case, the IFR also can save time. In the previous slides, I introduced the FFR and IFR. Both FFR and IFR are good for the coronary stenosis-induced myocardial ischemia. But we know most of the some patients have the microvascular disease. The microvascular disease means the microresistance have some problem. In the coronary system, the microvascular resistance is in the arterial bed. That means the arterial diameter smaller than 200 micron. So Dr. William Faven proposed a new parameter, the IMR. IMR equals to the PD times TMN as a maximal hyperemia. The PD is a mean pressure distal to the stenosis as a maximal hyperemia. TMN is a thermal dilution wire measures a time period. TMN is inversely proportional to the flow velocity passing to the distal point. So we propose several other parameters. I will introduce them in the following slides. The IMR have different applications. For example, a patient who has an abnormal stress study and angina, but has no significant epicardial coronary lesions. A patient is successful for PCI, but continues to have angina. Also, a patient presenting with acute coronary syndrome. Also, a patient with a stable patient is a stable patient, but after PCI, he is still uncomfortable. Another very important is a patient after heart transplantation. Both FFR and IFR are the class 1A recommendation for guiding revascularization. But in the world, the use of the FFR and IFR are still is still low in the coronary cath lab. The IMR is even lower. The major reason is the pressure wear is inconvenient, is still invasive method. Using the pressure wear, it doesn't matter from the Abbott or the from Philips. It's inconvenient. We have to put it distal to the stenosis. So first, the Dr. Charles Taylor from Stanford University proposed the FFRCT. FFRCT is just based on the coronary angiogram, the routine coronary angiogram, and as well as some mathematical model. For example, the epicardial coronary arterial tree, the resistance for the epicardial coronary arterial tree, and some other three elementary models. They use a CFD model to calculate the flow distribution in the epicardial coronary arterial trees. And then they can determine the fractional flow reserve in each point. Normally, I think Dr. Charles Taylor still use my patent in the United States to determine the coronary resistant, to determine the resistance at each outlet of the epicardial coronary arterial tree. But the CT-FFR is good for when the FFR is smaller than 0.7 and FFR is larger than 0.85. If a FFR larger than 0.75, smaller than 0.85, the accuracy is not good in comparison with the pressure wear measurements. The accuracy is only 50% to 70%. As we know, 5% is a significant improvement for a device. So there is a new technique from there was a new technique in 2013. I think it should be 2013. Dr. Tu Shengxian, he's also from Shanghai Jiao Tong University. He proposed the angiography-derived FFR. Using the angiography-derived FFR, that normal case is using from the angiogram based on the angiogram from two projections, we can use some technique to 3D reconstruct the coronary arteries, and then based on some method. The traditional method that's from Tu Shengxian and also from CAS work, they use mathematical formulas to determine the FFR in the coronary arteries. Last year, the year before last year, we proposed a new technique using the CFD model to calculate the FFR. And also, the CFD model is specially designed. Our calculation time is only 15 to 30 seconds. Using the angiography-derived FFR, in this case, we don't need for the wear manipulation. Also, we don't need a hyperemia stimulus. In the world, there are only 3 companies to finish the clinical trials, the prospective and the multi-center clinical trials. That's Medis QFR and Castwork FFR Angel, and also RainMed CAFFR. And I remember there is a Pi company, they're doing the clinical trials, but I'm not sure they are finished or not. The basic theory for the coronary angiography-derived FFR is we based on the angiograms from 2 projections and carry out the 3D reconstruction of the coronary arteries from the inlet to the most distal part. In this part, we can use a TIMI method to determine the flow velocity. We have the flow velocity in the CAFFR. We propose a new method. We have a new device we call the aortic pressure wave monitor. Using this one, we can get the instantaneous aortic pressure waveform and then put the waveform into the console. This one, in combination with the angiogram data, we can use a CFD model, the specially designed CFD model, to calculate the pressure drop from the inlet down to the most distal part. In this case, we found it's very accurate. So we carry out the FLASH-1 clinical trial. The FLASH-1 clinical trial is we evaluate the diagnostic performance of CAFFR compared with invasive FFR in 330 patients. In the clinical trials, there are 2 patients we cannot get the angiogram. So in the final case, in the final case, we only have 322 patients. In those patients, 14 patients had a significant pressure drift, and 2 patients have myocardial bridge. But in the statistics, in the statistical results, we covered all of the patients. That means we covered 328 patients. In all of those patients, we have the LAD close to 60%, LCX close to 11%, RCA is close to 26.5. We have 26.5 bifurcation lesions, and also the 26.5 bifurcation. Oh yeah, 26.5, yes. And also the calcified lesions close to 18%. In the 328 patients, this is the frequency of the FFR distribution. From the frequency FFR distribution, we can find most of the FFR is in the range from 0.65 to 0.95. The mean FFR value equals to 0.83. FFR smaller than 80 is close to 35%. FFR is larger than 0.7, smaller than 0.85, is close to 36.3%. The final results for all of the vessels, the accuracy is 95.7%. If we didn't include the myocardial bridge and also the pressure drift, our accuracy is about 96%. The sensitivity is close to 91%, and the specificity is close to 98%. The diagnostic accuracy for the FFR larger than 0.75, smaller than 0.85, is close to 90%. Now it's 89.9%. But if we didn't include the myocardial bridge, also we didn't include the pressure drift, our accuracy is 91%. That means in the gray zone, using the CFD model, in coupling with aortic pressure wave, our accuracy is still above 90%. Why we need the instantaneous velocity, instantaneous aortic pressure waveform? Because we summarize our data. We found if we fix the aortic pressure to 60%, we can find the accuracy drop to 70%, and the FFR in the gray zone drop to 56%. If the pressure is fixed to the 100, that means the total accuracy still decreased lower than 90%. So we can conclude the CAFFR is fast. The total operation time is smaller than 4 minutes. The CFD computational time is only 15 to 30 seconds. Also, we have the theoretical advantage to in coupling accuracy, exactly the blood pressure waveform that can improve its accuracy, particularly in patients with FFR value in the gray zone. The left figure shows the relationship between the QFR and the pressure wire measured FFR. This one is from the Dr. Huo's publication. The middle figure is from the relationship between the casework flash angle and the pressure wire derived FFR. This one is from Dr. William Phelan's publication. The right figure is a relationship between the CAFFR and wire-based FFR. From the figure, we can find there is a good correlation between the CAFFR and the wire FFR. The basic theory for the three candle products are almost the same, because we get the 3D construction of the coronary arteries from the angiograms from two projections. But the computational model are different. The casework FFR angle using the lumped model. MEDIS using a mathematical model. RainMed, the CAFFR, we use a CFD model. In the casework FFR angle, they read PA value, that mean aortic blood pressure, from other machines and input this value into their machine. And also MEDIS using a constant value. I remember they use 80 millimeter mercury. The RainMed FFR flash angle using the aortic pressure waveform input to the RainMed flash angle console. We can determine, we can improve the accuracy for the FFR, the angle-derived FFR. There is a small summary for the CAFFR. This part is we don't need wire manipulation. We don't have the hyperemia stimulus. Also, we are very fast. The most important is we are much more accurate than CTFFR. In all of this case, there is one limitation. This limitation is it doesn't matter for CTFFR or angiograph FFR. We use an empirical model to calculate the hyperemia blood flow from the resting blood flow, because we get the flow velocity only from the resting blood flow. This empirical model, different company has different form, but the basic theory is we estimate the hyperemia blood flow. So I propose two new parameters. The first parameter is a coronary angiography derived DPR, that's a diastolic pressure diastolic pressure ratio, and CAIDMR, that's a coronary angiography derived index of the diastolic microcirculatory resistance. Because we have the aortic pressure waveform. Based on this aortic pressure waveform, we can determine the diastolic period. In this diastolic period, we can determine the pressure, mean blood pressure. And also based on the angiogram, we can get a 3D reconstruction of the coronary arteries from the inlet to the most distal part. Also from the angiogram, we can get the flow velocity at diastole. That means diastolic flow velocity. All of this part in the resting case. We know the DPR has an equivalent, the DPR is a numerical equivalent to the IFR. They are exactly same, no different, even for the cutoff value. So we can use the DPR to mimic the IFR. Also, we can use the CADPR to get the, we don't need the empirical model. From the theory, the CADPR can get the exactly consistent with the DPR and IFR. The CADPR equals to the PD over PA. PD is a diastolic pressure waveform after the distal to the stenosis. PA is a diastolic aortic pressure waveform. CAIDMR is a PD is a diastolic pressure waveform distal to the stenosis, and the V distal is flow velocity passing that point during as a diastolic period. L equal to 7.5 centimeter. So we propose these two parameters. Using these two parameters, we can get the resting physiological parameters very similar to the pressure wire measured IFR and the pressure wire measured DPR, or the pressure wire measured RFR. Because in China, there are no many hospitals using the IFR. So we have to first carry out the retrospective study to evaluate our CADPR. Still using our CAFFR data, we compared with the relationship between the CADPR and the pressure wire measured the FFR. We found the diagnostic accuracy is close to 87%, close to 87.7%. The sensitivity and specificity are above 85%. We have the mean FFR value is 0.83, and the vessel with FFR smaller than 0.8 is 75%. But the CADPR, we have the mean value is 0.89. The vessel with a CADPR smaller than 0.89 is close to 40%. That means our CADPR is very similar to the pressure wire determined IFR. It can increase the stenting case. The left figure shows a relationship between the CADPR and the wired base FFR. From the figure, you can find there's a reasonable. I think there is a reasonable relationship between the CA-DPR and the CA-FFR. The red figure shows the AUC value. So we can find AUC value is equal to 0.94. It's still very good. Also, we carry out the retrospective study to evaluate the CA-IDMR. This one I call the IDMR is the index of the diastolic microcirculatory resistance. In this case, we use diastolic period. IDMR can mimic the IMR. In this case, we don't need the pressure wire, only based on our angiogram and also our aortic pressure waveform. We got this new parameter, CA-IDMR. In China, in 2 hospitals, we evaluate the diagnostic performance of CD-IMR compared with the invasive wire-derived IMR in 42 patients, include 44 vessels. Those patients is with stable or unstable angina pectoris and no severe stenosis. I emphasize, in current situation, we only evaluate this patient, no severe coronary stenosis. In those patients, the stable angina pectoris is 57%. Unstable angina pectoris is 21%. No previous myocardial infarctions. Because still now in the IMR, there is no good cutoff value to estimate the microvascular resistance. Some doctors, for example, Dr. Lee from Korea, he emphasized the cutoff value maybe the 26. Other doctor like Dr. Freeman, he thinks the cutoff value is 30 or 35. So we use different cutoff and based on the AUC value to determine the IDMR, the CA-IDMR cutoff value. We found when the IMR cutoff value equals to 25, the IDMR cutoff value is 35. And the AUC value, we can get the good AUC value is above 0.9. That means above 90%. The accuracy and the sensitivity and the specificity, all of them are above the 80%. So we suggest that if the IMR cutoff is 25%, CA-IDMR cutoff is 35%, maybe a good measure to diagnose the microvascular resistance. The left figure shows the relationship between the IDMR, the CA-IDMR, and the IMR. The right figure shows the AUC value. This one is IDMR equals to the cutoff value of the IDMR is 35, and the IMR is 25. Also, there is a small summary for the CA-DPR and the CA-IDMR. We don't need for the wire manipulation. Also, we don't need a hyperemia stimulus. We are much faster than the wire manipulation because for the IMR measurement, you need to inject the ceiling 3 times. We don't need to inject any part, only based on the angiogram. Also, a combination of the CA-DPR and the CA-IDMR may be useful for the physiological assessment of the macro and the microvascular disease. But this part, we still need more clinical validations in the following studies. Finally, in this June, we will start the FLASH-2 clinical trial. clinical trial. In this part, we will investigate if the CAFFR diagnostic strategy will result in non-inferior clinical outcomes after 1 year compared with the standard FFR-guided revascularization strategy. That means we will compare it with wear-based FFR. The primary outcome measurement is a composite endpoint of the all-cause mortality, but we will not include the perioperative period. Also, the second part is any myocardial infarction and any unplanned revascularization. This part we will start to enroll the first patient in this June in the Peking University First Hospital. Thank you.